Assalamu alaikum. Inshallah, our topic today about diabetic kidney disease. What is new? So in this topic, we will talk about diabetic kidney disease, an overview at the beginning, and then we will focusing on the management, where the most of the recent change from 2022 is in the management. Diabetic kidney disease, defined as persist reduced glomerular filtration rate and or increase in albumin, urinary albumin secretion for at least 3 months. In terms of the epidemiology, as all of us know, the diabetic type 1 is the prevalence in around 30% and type 2 in around 40%. And their increase in the prevalence of diabetic kidney disease is associated with increase in the prevalence of diabetes. Here is a nice picture that showed the prevalence of type 2 diabetes among different studies from different countries. As you can see, there is the blue color for the albuminuria and the yellow color to present the reduced GFR. And in between, if the patient have both of them, and all of us can notice that the prevalence of albuminuria is more than just only reduction in GFR. All of us know diabetes is the most common cause of end-stage renal disease. It's associated with morbidity and mortality. And the most important marker is albuminuria because it's detected the mortality in this population. Also, all of us know there is a relation between uncontrolled diabetes and the increase of incidence of a chronic kidney disease. So let us talk a little bit about the structural change in diabetic kidney disease. So usually we have type 1 diabetes and type 2 diabetes. In type 1 diabetes, usually the changes start in a range between 1.5 and 2.5 years. Started with the thickening of the basement membrane, then there is a mesangial expansion, then after that they can have the most specific sign of diabetes, that is the camel stone Wilson nodule, which is in the lower picture, the purple color nodule. So we can notice type 1 diabetes, most of the changes have been related to glomerular disease. In type 2 diabetes, it's more complicated. So we classify them usually pathological to 3 types. Class 1, the classic one, so they have a glomerular disease associated with diabetes. Class 2, when they have a normal glomerular structure, but their changes related to the reduce in GFR. And the class 3 usually divided to 2 classes, class 3A and class 3B. Class 3A, if they have superimposed of other glomerular disease on the glomerular change, they have it related to diabetes. And the class 3B, if they have a non-glomerular disease associated with diabetes. Class 3 usually account for the 50% of the cases. And here we can see a different picture from the pathological type 2 diabetes. So what is the natural history of diabetic kidney disease? So usually it's divided to 5 stages. Stage 1, usually when the patient, especially with the type 2 diabetes, have a hyperfiltration. So usually they have a very high GFR, like 95, even some of the patients, they reach up to 110. These population usually they have no albuminuria and their blood pressure is normal. Stage 2, when the patients start to be having or notice some change, so they might have an intermittent microalbuminuria. It could be sometimes associated with a normal blood pressure. There is a good number of the patients, they stay in this stage for the rest of their life. Stage 3, when the patients start to have the microalbuminuria became present, they have a mild hypertension, and some of them, they start to notice some decline in their GFR. Stage 4, if they have a macroalbuminuria, hypertension, and significant decline in GFR. Stage 5, if they have end-stage renal disease. Here is a nice picture, shows the different change with the different timetable. So when we're talking about the microalbuminuria, we can notice it's happened after at least 5 years. If we talk about the hypertension, is the same, it's happened around 5 years. The cardiovascular risk start to develop after 15 years, and the kidney damage in a 20-year-old. For the screening of the diabetic kidney disease, all of us know type 1 diabetes. Usually we screen after 5 years from the diagnosis, but for type 2, usually we usually doing the screening at the time of diagnosis. We use the urinary albumin to creatinine ratio and the serum creatinine plus the estimated GFR. So when we test for the microalbuminuria, we cannot say the patient have a microalbuminuria from one test only. So we need to rule out there is no transient microalbuminuria in these patients. So to confirm the diagnosis, usually we need to have 2 out of 3 positive tests. It's supposed to be done within 3 to 6 months. And after that, we can confirm the diagnosis. Let's talk about the most important part, the management of diabetic kidney disease, what's new in the management. So the KDIGO guideline usually updates their recommendation or their guideline in 3 to 5 years. But a lot of it change happening between 2022 and 20 and 22. So they updated their guideline in 22, where the last one just was published 2-year barrier to that. So KDIGO have 5 important targets for treatment of diabetic kidney disease, including the comprehensive care in the patient who have diabetes and chronic kidney disease, the glycemic monitoring and targeting in patients who have diabetes and chronic kidney disease, the lifestyle intervention, the glucose lowering therapies, and approach to management for the patient who have diabetes and chronic kidney disease. The recent guideline from 2022 have most of the update related to the comprehensive care and the glucose lowering therapies. So let's start with the comprehensive care. So KDIGO recommended a comprehensive care aiming to reduce the risk and the progression of kidney disease and cardiovascular disease. So between 2020 and 2022, we can notice a lot of a change going on. Prior to that, we just giving for all the patients the lifestyle intervention and to using the medication that approved the cardiorenal protection, which was the sodium glucose co-transporter inhibitor and the RAS, and using other medication related to the cardiovascular protection. But in 2022, there was a lot of a change, started with the lifestyle that is include the weight reduction too, in this new changes. Also, the medication that have a cardiorenal approval, including many medication, even in the first line therapies such as the sodium glucose co-transporter, the RAS, or a second line therapy such as the GLP-1 and the non-steroidal mineralocorticoids inhibitors. Also, they're focusing on the time to be monitored for the risk, such as the lipid control, the blood pressure control, and the glycemic control. That's supposed to be reassessed every 3 to 6 months, and it's written on the first time in their recommendation. Also, when they came, this is another picture showing how we should care for the patient who have diabetes. And we can notice this time is not only talking about type 2 diabetes, they start to talk about the risk factor that including for type 1 and type 2 diabetes, plus how we can manage specific for type 2 diabetes. So as we can see, the first line therapy seem to be the sodium glucose co-transporter and the metformin for type 2 diabetes only, but the RAS for type 1 and type 2 diabetes, and the statin for all of them too. In terms of the second line therapy, the GLP-1, it's one of the agents to control for the blood sugar, and also showed a cardiac protection and promising renal protection. Also, we have the non-steroidal mineralocorticoids as a cardiac and renal approval for controlling of the albuminuria and hypertension. This medication is recently just added to the guideline from 2022. So let's start with the first medication. So in our next few slides, we will focusing about the medication that showed a cardiorenal protection, started with the sodium glucose co-transporter, the RAS, and then non-steroidal mineralocorticoids. And we will talk also about the GLP and about the metformin, briefly, where they approved a cardiac protection. So the KD board recommended to use the sodium glucose co-transporter even if the GFR equal to 20, which is seemed to be different from the previous guideline, where they said more than or equal to 30. And in the recent guideline, they start to drop. So it seemed to be a medication that be able to use it even for stage 4 chronic kidney disease. Also, from their recommendation, it's coming from that they find this medication is safe and effective to reduce the risk of a chronic kidney disease among the patient, the chronic kidney disease and the to reduce the cardiovascular and kidney disease among the patient who have diabetes and the chronic kidney disease, even if they have no diabetes. And since this medication associated with the less risk of hypoglycemia, they even advise to be using or as an added agent for the patient who's already using a different other medication. So from where that is coming, as we know, there is a many clinical trial done on this medication, but for us as a nephrologist, there is a stop 7 trial that changed our recommendation, that including the IMBA-RED, the CANVAS, and the Clear TEMI 58. These 3 trials have a primary outcome for the cardiovascular and secondary outcome for the kidney, and this medication approved a beneficial. The Imperial Reduce trial that is done on the patient with the heart failure, and they divided the patient to GFR less than 60 or more than 60, and with the primary outcome for the cardiovascular and secondary outcome for the kidney, and also it showed a beneficial for the kidney. Also, there is 2 large trials, the Credence and the DABA CKD. Both of these studies focusing for the primary outcome on the kidney outcome, and this medication showed a beneficial. And the last one was the SCORE, the trial with the primary cardiovascular outcome, but the patient, they are ruled that they are the patient who have a diabetes and a chronic kidney disease, and also showed a beneficial. For us, still Credence is the most important trial because it was the first trial with the primary outcome on the kidney disease. So they randomized the patient to receive the canagliflozin or placebo and follow them for 2.6 years. Where the primary outcome for the kidney was if the patient developed end-stage renal disease, doubling of serum creatinine, death from renal or cardiovascular cause, and they found 30% relative reduction associated with the canagliflozin. Here is a table that showed the most approved medication, which are 3 medications. The first one is the dapagliflozin. And it's approved to be used even if the GFR more than or equal to 25, and that was based on the clinical trial from the DABA CKD. The second one is the empagliflozin, and it's approved to use if the GFR more than or equal to 20, and that was from the Imperial Reduce trial. And the canagliflozin, as we discussed from the Credence study. So here are the many clinical trials done related to the kidney, related to the cardiovascular, and related to the heart for this medication. But still we have insufficient data for the patients such as type 1 diabetes, who have a chronic kidney disease, the patient who have a kidney transplant, or the patient who are on dialysis, because this population is still excluded from all of the trials done. But giving all the benefit this medication have, we urge to have further research in the future, looking for the benefit of this drug in this population. This medication might not be suitable for all the patients because it has many adverse effects, such as increase the risk of the genitourinary infection associated with the volume depletion, ketoacidosis, decrease the bone mineral density, and it can cause acute kidney injury. There is a nice guide from one of the articles that published in the Journal of American Society of Nephrology at the end of 2021 that giving for us an estimating how we could assess who's the patient suitable for this medication. So usually it's the patient who have GFR more than 20 or equal to 20, have albumin creatinine ratio more than or equal to 200, and to exclude the patient who is using immune suppression, having foot ulcer, have a higher risk of genital infection, or the patient who have a risk for ketoacidosis. We can start either of the three medication, and we should educate the patient about the stuff, to have a food care, to have a sick day protocol, and to be and make sure about adjustment of this medication before any surgery. And we're supposed to be following up for any side effect. For the patient who have an issues with their glycemic control, such as the patient who develop a frequent episode of hypoglycemia, even secondary to the other medication they use, or because their hemoglobin A1C is in the lower normal. So these patients, usually we advise them for a close monitor for their blood sugar and even to readjust the other medication. And for the volume depletion, specific for the patient who's using a diabetic, we might need to adjust this medication. So the second medication is the ACE and ARBs, which is also KDIGO recommended to initiate them for the patients who have diabetes to control their blood pressure and at the same time to control their albuminuria. There are many trials that show the benefit of the ACE inhibitor and ARBs. One of them is the IRMA study that done for the irbesartan, and it was showing it has reduced the progression of a chronic kidney disease by threefold. The innovation trial, which is done on the telmisartan, and it was associated with delaying the progression for the nephropathy compared with the placebo. The IDNT trial, which is also showed the irbesartan compared with the placebo, have 33% decrease in the risk of doubling of serum creatinine. And the renal trial, which is showed that the losartan was reducing the incidence of doubling serum creatinine, kidney failure, and death, each one by 16% comparing with the placebo. The last one is the concurrent systematic review that showed the use of ACE or ARB treatment in a patient with diabetic and chronic kidney disease associated with the reduction in the progression of chronic kidney disease with regarding the development of severity, increased albuminuria with a relative risk of 0.45 or doubling serum creatinine with a relative risk of 0.68. But all of us, we should know to be advising contraception for the women who should be initiated on ACE and ARB, and to discontinue this medication for any woman who's planning to become a pregnant or she's became a pregnant because it is a teratogenic medication. And usually, remember, we don't use two agents together because of the higher risk to develop a severe hyperkalemia. So use one agent at a time. So as we know, most of the studies confirm that ACE and ARBs are usually associated with a hyperkalemia or increase in the serum creatinine. Because of that, usually we advise to monitor in 2 to 4 weeks after we initiated these drugs. If the patient have a normal potassium and normal or the increase in serum creatinine less than 30%, we do nothing in terms of the treatment. But if the patient having a hyperkalemia or increase in serum creatinine by more than 30%, we need to reassess if we have any other medication or if the patient develop an acute kidney injury or other explanation causing why his serum creatinine increased or why he have a hyperkalemia. If there is no obvious cause, usually we need to be discontinue the medication and restart it with a smaller dose. So the third and the new medication to the guideline, which is an non-steroidal mineralocorticoid receptor antagonist, that is approved a kidney and cardiovascular benefit in type 2 diabetes, especially for the patient with GFR more than or equal to 25. And they have a normal serum potassium, and they have albuminuria more than 30 milligram per gram. But those patients already treated with a maximum dose of ACE or ARMS, and they didn't respond. So there are two large clinical trials done for this medication, the Fidelio DKA and Figaro DKA. Each one of patients who have a type 2 diabetes with a maximum tolerated dose of the RAS inhibitor, who had an albuminuria more than 30 milligram per gram. Their serum creatinine was, their serum potassium was less than 4.8, and the mean GFR was 57.6. And then they they assigned a patient even to receive the fine renal or a placebo. So for the Fidelio study, they showed that the fine renal was associated with reduced the incidence of both primary kidney outcome, such as a kidney failure, sustained increase by more than 40% in GFR or death from the kidney disease, and also benefit for the secondary outcome, the cardiac. Figaro was focusing on reduce the cardiovascular risk, and it was significant with a hazard ratio of 0.87. From the picture we saw before, usually RAS was recommended to use at the same time with the sodium glucose co-transporter, but we still have lack of evidence to use this medication with the sodium glucose co-transporter. Given the sodium glucose co-transporter associated with decreased potassium, so it might be benefit for this population. And again, as any medication we use it, we usually looking for the side effect and to make sure how we should monitor this medication. This medication is associated with increased the potassium. So usually we're supposed to start the patient if their potassium less than or equal to 43. And usually if the GFR less than 59, we're supposed to use the dose of 10 milligram. If it's more than 60, we can use up to 20 milligram. We need to monitor for the potassium as we did with the RAS inhibitor, and reassess if the patient have any other medication that need to be discontinued before we start this medication, such as the non-steroidal anti-inflammatory drugs. So if the patient have increased in their potassium to 4.9 or 5.5, we can continue the same dose of the medication. But if it's more than 5.5, we need to stop the medication, reassess the patient, and restart with the small dose. So the fourth medication we will talk about is the GLP-1RA. Which is recommended as a second-line therapy after the patient used the metformin and the sodium glucose co-transporter, who still don't have reached a glycemic control, or the patient who cannot use these medication. Regarding for this medication, there is one of the new trial, the Amplitude-O study, that showed an evidence for cardiovascular benefit for this medication, and there is a promising also for kidney outcome improvement. This medication is associated with a very beneficial effect to reduce the weight. So it might be considered, especially for the patient who have a chronic kidney disease, and these patients could be beneficial from this medication in the future if we consider them for the transplant. So they will not facing any issues with overweight. Metformin is an old medication in the market, inexpensive medication, better to be started with all the patient, and also it showed a cardiovascular and even questioning about renal beneficial to reduce the progression. The second target is the glycemic monitoring and targeting in patients with diabetes. So KDIGO recommended to have the hemoglobin A1C less than 6.5 and to less than 8. That is basic on the patient condition and to be avoiding the risk of hypoglycemia. But this guideline is not fitting for the patient who are on dialysis. So when we talk about 6.5, it's for the healthy patient. But when we talk about less than 8, we talk about the patient who have multiple risks, such as a severe CKD or the patient who have a higher risk for hypoglycemia. So we advise for all the patients to have monitoring, self-monitoring for their blood glucose that can prevent the hypoglycemia, especially in patient stage 3B when they're using an oral hypoglycemic that might be stay because most of these medication is excreted by the kidney. So it might be stay in the body for a longer time. So they may have a higher risk to develop hypoglycemia. And usually remember the medication associated with the higher risk, such as the insulin and sulfonylurea. So we set the target for the hemoglobin A1C less than 6.5 or less than 8 is fitting for the patient with a chronic kidney disease, but we don't prefer for the patient who have an advanced kidney disease or patient who are on dialysis. Because from a previous lecture, we just talking about some of the factors that can play a role to have a false increase or decrease on the hemoglobin A1C. Chronic kidney disease associated with many of these factors. So it can have a high bias if the patient have a metabolic acidosis, and it could be associated with the low bias if the patient have anemia or they using the erythropoietic stimulating agent. Then the third target was the lifestyle intervention in a patient who have diabetes and chronic kidney disease, and this is the same as all other guidelines recommended. Patient should be on a DASH diet, should have a sodium intake less than 2 grams per day, should be exercising for at least 150 minutes per week, and for the protein intake to be limited to 0.8 grams per kilogram per day for the patient who are not on dialysis, because dialysis will have a different equation. And we advise the patient to stop smoking. For the anti-hyperglycemic therapy, there is nothing changing from 2022. Metformin and sodium glucose transporters is still the first line therapy. And here is a nice picture, even published from 2020, that showed usually we start with the lifestyle intervention. Then after that, the first line therapy, metformin and the SGLT inhibitor. And we can see from the picture, the metformin, we cannot use it if the patient have GFR less than 30. But for the SGLT inhibitor, we supposed to be not use it if the GFR less than 20, or if the patient started already on dialysis, and GLP receptor and agonist is still the first, the second, the preferred second line therapy. Here is a nice table that showed the different dosage of the oral hypoglycemic agent and insulin with the different GFR, where we can see the linagliptin is the only medication orally. You can still use it while the patient on dialysis without adjustment for the dose. And the sitagliptin, we need to adjust the dose even to be used on dialysis. Insulin, usually we are not adjust the dose basic on the GFR, but we adjust the dose basic on the reading of the blood sugar. And the last target was the approach to management of patients with diabetes and chronic kidney disease. So usually we're supposed to have a self-management education. Patient should be understand his disease, be aware from the side effect of the medication he's taking, and at the same time, patient able to be also knowing more about the new stuff is coming. And the multidisciplinary team is playing a major role to have a focused care that aim to reduce the risk of the cardiovascular and renal complication associated with the diabetes, and at the same time to give a comprehensive care for the patient who have diabetes and chronic kidney disease. So nephrologists should be a part of the multidisciplinary team for diabetes. Here is the last slide that summarizes whatever we talk about. So usually it's like a quality reassurance cycle. Usually we started with the comprehensive care to prevent any cardiac or renal damage, controlling for blood sugar. Patient should have a self-management to be understand what we're doing. Usually when we choose the first or the second line agent, we should looking for the medication that have at the same time and beneficial for the cardiac and renal system. Usually, we should look in for the glycemic control where the patient stage of the chronic kidney disease, and the life intervention is the most important target too. Usually, this stuff is helping us to targeting the blood pressure, the lipid profile for the patient, the hemoglobin A1C, the albumin to creatinine ratio, and the GFR, which is supposed to be reassessed and every 3 to 6 months, and adjusted medication based on that. Thank you so much.